So on this next clip, we'll go through monitoring of your baby and some pain relief that you'll be offered when you are in labour. So when you come in, you've been monitored, as Sue just said, you're 4 centimetres, strong, long, regular contractions. The first thing they'll do is monitoring babies. So if you're on the midwifery led pathway, what we'll do is listen in with the sonic aid that your midwife's been using in clinic, and she'll be listening in every 15 minutes in that first stage of labour and after every contraction in the second stage of labour. If for whatever reason she's worried about your baby's heart rate, they might pop you on the CTG monitor, and that's what you'll have if you're consultant led, because we need to monitor your baby more closely for whatever reason that you're being consultant led. You will be placed on the monitor, so it'll be a strap here and it measures, this one measures your contractions, and then a strap and a transducer here or here, wherever they're picking up your baby's heart rate to monitor that baby all the way through. So that's the monitoring that you'll have, and that'll be decided by whatever's happening in your labour at the time. So they've started monitoring baby. What sometimes happens when we monitor baby is they wriggle around, and sometimes we can't get a clear reading of what that baby is doing. So what they'll offer you is, it's called a fetal scalp electrode. It's a little clip that goes onto the top of the baby's head, and that actually measures the ECG of your baby. It measures the actual heartbeat rather than just giving the heart rate, and it can give us signs if your baby is not coping as well as we would expect in labour. If your waters haven't broken, they will break your waters first. And then what we do is insert this vaginally, and then this little clip at the top goes onto baby's head. It doesn't hurt them. It's only on the very top of their head. And what they'll do is attach that, and then they attach the end bit, and that goes into the monitor then. And that gives us a much closer look at baby and how baby is coping. So that's that. So you've had your monitoring. You're either on the monitor or we're listening intermittently. Doesn't matter how you're being monitored. You do not have to sit on your bed or lie on your bed. You can get up, you can go on your ball, you can get on your hands and knees over the back of the bed, you can move around as long as it's not far from the monitor if you are being continuously monitored. But what we want is that gravity, so you can stand up, you know, like I said, over the back of the bed, moving around. Gravity is going to help with that baby and the dilation of your cervix. So we've done that, and now what they'll do is offer you some pain relief. As I said before, the TENS machine that you can use in the early part of labour, and it's got the 4 pads, which, as Sue said before, 2 of the same colour go on here, and then 2 go here. The instructions will be inside of your TENS unit. If you've bought one or if you've rented one, that'll show you where to.
And you'd come in with this on. You wouldn't take it off to come into hospital, would they? You know, you'd keep this on. So we don't provide them in hospital. You have to have them yourself, okay?
And you can use that with different forms of pain relief as well. So that's your TENS machine. Your paracetamol and cocodamol they might offer you if you didn't want to try anything else. Next thing we can offer you is gas and air, the Entanox. That's piped into every delivery room in the hospital. And what that is just gas that you breathe in all the way through your contraction, and then stop once the contraction's gone. So you're putting your mouth right over the mouthpiece, and you're sucking all the way in. So, and breathing out. You don't have to take your mouth off the mouthpiece. You can just keep your mouth on and breathe in and out on this. This is also good for making you think about how you're breathing as well, because it slows your breathing down. Taking good gulpfuls. It only lasts for however long you're breathing on this. It doesn't cross the placenta, it doesn't do anything else, it just lasts for when you're breathing. So you need to be regularly breathing on this. Start when the start of your contraction starts, and then take it out when your contraction ends. What I will say about this is a lot of people say it makes them feel sick or it makes them feel very spaced out and not in control. Use this for at least 5 contractions. Once you get used to that feeling of not being in control and that bit of spaced out feeling, this you will then, if anyone tries to take this off you, you'll probably be a bit like the Exorcist, your head will spin and you'll grab hold of it and not let anyone have it. But just try it for 5 contractions. If you don't like it, then obviously give it back and the midwife can suggest something else. You can use this with water, so if the pool's available for you to use, you can have the water and you can use this. And this Entonox can also be used if you have pethidine. So if you needed something extra rather than the Entonox, your midwife can offer you pethidine, which is an opioid that does cross the placenta, but only in a very small amount. If you're close to delivering, your midwife might dissuade you from having the pethidine, because if you have it too close to delivery, it crosses the placenta and it can make your baby sleepy and less willing to breastfeed when baby's born. So that's the Entonox pethidine. And then if all else fails and you're just not getting any pain relief from any of the things we've offered you, then we can offer you an epidural. So, yeah, I will hand you over to Sue.
So the epidural is the injection of local anaesthetic and painkillers that will numb you from here down. And the way it's offered to you is through an injection into your back. Now, the thing with the epidural is it's a fiddly procedure. You're usually in a lot of discomfort. You'd be using your gas and air at the same time. The idea is that the injection goes in between your vertebrae here, and if you think of how we stand, our vertebrae are all sort of overlapping a bit, so you have to have a cat-like exercise that opens out the vertebrae to allow the anaesthetist some space to insert the injection. If you think about how your spinal cord comes down the centre of your vertebrae here, you've got your spinal cord coming down and then the nerves coming out around your tummy here, and they want to put local anaesthetic in so that it's then going to wash over those nerves that are coming around your tummy here, that's then going back to your brain to telling it it's in pain. It's a bit like when you have an injection at the dentist of the local anaesthetic. It's sort of numbing the nerves that are feeding that area for that particular tooth they're operating on. And so the same is with an epidural. So if you were going to have an elective cesarean, you would have a spinal, which is like a one-off injection of the epidural. But because you don't know how long your labour is going to last, it has to have a tiny catheter inserted into around the spinal cord. It goes into the epidural space, which are the 2 layers of membranes going around the spinal cord. And you can see here, it goes in here. The little tiny catheter then is taped up your back. You then have the little valve here taped to your £5 pre-melt nightie, and they can do top-ups in here every hour of the local anaesthetic and painkillers for however long your labour's going to last. They work really well generally, but what can happen is if you've got a little kink in the way your back is with your discs or anything, or if you carry a bit of weight here, they're a bit trickier to insert. So the needle will go in first, this will go through the needle, and then the needle is removed and this is left in. Sometimes, if it's kinked one way, you might get a fantastic epidural on this side, but nothing on this side. So the anaesthetist will come back and reposition it. To get you into that initial position, it's tricky. You're 9 months pregnant. They'll usually get you to sit on the bed, not like John Wayne, but sitting on the edge of the bed, and they'll get you to push out your lower back here. I'm going to alter the camera down a tad so you can see again. So they'll ask you to push out here. So you have your 9-month pregnant tummy, you have your trusty gas and air in your hand here. Rachel, have some gas and air. And your partner, we would always advise to stand this side of you, okay? This is going to be quite an anxious time. You might have been in labour quite a while. It might be that your lovely darling baby is a bit back to back in here and is taking a long time to rotate around, and that's why your labour's taking so long. So you've been quite uncomfortable and you might be tired, you might have been up all the previous night. The anaesthetists are the most patient of doctors. They'll work with you in between your contractions. You'll breathe your gas and air In between the contraction, then they'll find out the place where they want to put the epidural into, and they'll gradually put it in. You'll get another contraction, you'll breathe the gas and air, they'll wait again, and they'll do it again. They'll then put a test dose in, they'll then see how that takes effect, you'll get repositioned on the bed, and gradually, as the epidural takes effect, you'll gradually realise that actually you're not feeling your contractions anymore as painful. Can you imagine? You'll have to be monitored all the time, because although the epidural doesn't affect the baby per se, it can sometimes make your blood pressure drop a bit, and that will sometimes affect your baby's heart rate. So we need to keep an eye on that. You'll also not be feeling your contractions as well, so we need to monitor those contractions and make sure they're still coming nice and regularly. You might find that you're using the gas and air for the first short while after the epidural is started, and then, as I said, gradually you'll notice that you're not needing the gas and air anymore at all, and it's working really well, and you'll love the anaesthetist, and they're your new best friend. They usually come with an anaesthetist assistant to administer the epidural. We used to say that with an epidural you always had a forceps delivery. Not so much now, I don't think at all. But it might be the position of your baby that was leading you that way anyway, but at least you'll be comfortable when you've had it. So certainly not the first line of pain relief that you would have when you come into labour, but don't dismiss it completely, because it's a good thing to have if you need it. So go with the advice of the midwife that you're with when you're in labour, and how long your labour is taking. You know, if you arrive in the labour ward and you're 8 centimetres dilated and everything's going great, you probably wouldn't need one at all. But if you've had a long latent phase, you're already tired, you've had a long slog of a labour, the anaesthetist may well be the answer to all your labour dreams. You can still have a very normal vaginal birth with an epidural, okay? They just keep getting topped up every hour or so. As your labour continues, you'll find that it will be... I've lost my train of thought. As your labour continues, you'll find that if it ends up that it looks like you need to have a caesarean, they can top up the epidural to the level that you would need for a caesarean, and then the operation could just take place, okay? So we'll turn this off now. Bear with me.